Okay, let's go. Good evening and welcome to the third edition of The Right Dose, OPA's educational webinar series. I'm Ruth Ackerman and I'm the Director of Professional Development for OPA. Tonight we will be talking about the important public health role that pharmacists play in optimizing adult immunizations. In this busy flu season, more than in others, there are significant patient benefits for pharmacists to optimize their patient interactions by focusing on the patient and their requirements to maintain optimal health throughout this season. You know, this pandemic has brought many challenges, but has also shone a light on pharmacists like never before and the important role we represent as frontline healthcare providers. Now more than ever, it is critical to continue to do our part, helping to build capacity in the healthcare system and protect our patients. I'm sure you're going to enjoy this presentation. Before I introduce our speaker, I have some housekeeping details. In a reminder email you received prior to this meeting, you received the slide deck for this presentation, so you can follow along with Tiana. This presentation is CEEP accredited, and I'll talk a little bit later about how you get your CEEP credits. Your lines are muted, so if you need to ask a question, and please ask any questions that come up, we'll just put it in the Q&A box at the bottom of the screen. A lot of you already know the drill. So at this time, I especially want to thank Pfizer Canada for their support of this webinar. So our agenda is not too heavy. We have an introduction, that's me, and then we'll be quickly on to our presentation. There's a lot of stuff here to talk about. Then at the end of the presentation, we will go to a Q&A and we'll start to answer some of your questions. So before we go too much farther, I will introduce Tiana Tilley. And Tiana's going to take the screen share. So I'll keep talking about Tiana and her background. So Tiana received her Doctor of Pharmacy from the University of Toronto. While earning her degree, she participated in national and international advocacy efforts while interning at the World Health Organization, St. Mary's Hospital, Lacour in Gulu, Uganda, and the Ontario Pharmacists Association. Upon graduating, Tiana completed a hospital pharmacy residency at St. Michael's Hospital in Toronto. Following her residency, Tiana was a Health Economics and Outcomes Research Fellow at Becton Dickinson, Canada, where she provided her clinical expertise for their antimicrobial stewardship and medication safety portfolios. Tiana is now the Director of Pharmacy Innovation and Professional Affairs at the Whole Health Pharmacy Partners, where she leads the banner's clinical initiatives, including their adult immunization program. Tiana is an experienced speaker, having presented at conferences and forums for the Canadian Pharmacists Association, Canadian Society of Hospital Pharmacists, and Canadian Foundation of Pharmacy, amongst others. Tiana is passionate about optimizing the role of pharmacists and providing patient-centered care. She believes that innovative, patient-centered programs are the core of a successful pharmacy business and ultimately excellent patient care. Good evening, Tiana.
Hi, Ruth, and hi, everyone who's joined us today. Thank you so much for making some time to join us for today's webinar, Operationalizing Adult Immunizations. So today we'll be discussing the health promotion role for pharmacists in providing adult immunization recommendations, education, and vaccine administrations. We'll specifically cover how to proactively operationalize these services within your community pharmacy throughout COVID, this influenza season, and beyond. So I'd first like to disclose that I have received a speaker's fee from Pfizer Canada Inc., who does make several vaccines that we'll be discussing today. I will also be receiving a speaker fee from the OPA for creating and presenting today's program. At the end of today's session, you'll be able to compare COVID-19, influenza, and pneumonia to identify at least 2 similarities and 2 differences between these respiratory illnesses. Describe the public health role for pharmacists as it relates to immunizations, outline at least 5 infection prevention and control measures to operationalize during immunization services to protect against COVID-19, recall at least 4 vaccine recommendations for adults according to the National Advisory Committee on Immunizations, or NACI, and define maximizing the encounter as it relates to immunization services. So let's get started. COVID and pneumonia, influenza, oh my. So this upcoming season reminds me a bit about the Wizard of Oz, when Dorothy's on her way to the wizard and is scared of what's to come and is singing lions and tigers and bears, oh my. But we'll review together how these 3 conditions that all impact the respiratory system may impact patients and what pharmacists can do to protect patients from all 3 of these in their practices. We know that in a typical year in Canada, influenza and pneumonia, both respiratory conditions, are in the top 10 leading causes of death. On top of this, we're in the midst of a global pandemic, COVID-19, which may see a second wave, and we're already seeing a second wave this fall and winter. All 3 of these conditions are similar in multiple ways, including transmission, respiratory droplets, symptoms, overlap in terms of coughing, fever, feeling unwell, and patients who are at high risk of acquiring and experiencing complications from the conditions, older adults, and those with chronic comorbidities. There are differences between the conditions as well. For example, influenza has a shorter mean incubation period, which is the time from infection to appearance of symptoms, than COVID-19. And with influenza, children are important drivers of virus transmission, whereas with COVID-19, children appear to be less affected than adults, with household transmission typically occurring from adult to child. Regardless of the differences between these conditions, we need to do our part to prevent patients from experiencing any of these conditions, and this is especially important this year to prevent the healthcare system from being overwhelmed and overcapacity. We know that influenza leads to 12,200 hospital admissions each year, and that the average hospitalization due to influenza in adults lasts on average 10.8 days. We want to prevent influenza and pneumonia so there's healthcare system capacity for COVID-19. I'd like to take a few slides to review each of these diseases. I won't go into too much detail, but please feel free to reference them when talking to patients about the risks they pose and why we want to optimize immunization services to protect against them. At the time of recording, there's no vaccine on the market to prevent COVID-19, but there are candidates currently being evaluated. There are vaccines readily available against influenza and pneumonia, and these can be important recommendations to ensure that patients' lung health is protected as much as possible. Coronaviruses are a large family of viruses. Some infect animals and some infect humans. COVID-19 is a new disease caused by the coronavirus, SARS-CoV-2, and was declared a global pandemic in March 2020. As of August 31st, 2020, there have been 30 million confirmed COVID-19 cases internationally, with 216 countries, areas, or territories reporting cases. In Canada, there have been over 9,000 deaths. Common symptoms of COVID-19 include fever, dry cough, respiratory distress or difficulty breathing, and fatigue. This information on transmission informs our infection prevention and control measures, which we'll talk about later in this presentation. COVID-19 is primarily spread by droplet contact through direct contact, respiratory droplets released in respiratory secretions when a person with COVID-19 coughs, sneezes, or talks, and makes direct contact with mucous membranes of another person in close proximity. Droplets typically don't travel more than 6 feet, and COVID-19 does not seem to stay in the air, with the exception of aerosolizing medical procedures. Indirect transmission, which occurs in a person who touches a surface or non-living object that transmits disease-causing pathogens, and then touches his or her hands, nose, or mouth. Note that there's ongoing debate about transmission through fomites, and the risk is thought to be less than originally thought, with the greatest risk being when an infected person coughs or sneezes on a surface and someone else touches that surface within 1 to 2 hours. Being aware of high-risk populations can influence our practice by encouraging us to promote physical distancing even more so in these high-risk patients and promoting immunizations for other vaccine-preventable diseases so we can keep these patients as healthy as possible even in the event that they do get COVID-19. When we look at who's at highest risk of severe outcomes from COVID-19, we see that adults greater than and equal to 60 years disproportionately represent those in the hospital, in the ICU stays, and ultimately those who pass away from COVID-19. Despite having a smaller proportion of overall disease burden, 60% of all reported hospitalizations and all reported ICU admissions, as well as 90% of deaths, occurred among individuals greater than or equal to 60 years. Shifting to influenza, we know that seasonal outbreaks tend to occur in Canada between October and May, and that influenza A and B are the main viruses. Adults 65 plus are predominantly affected by influenza A strains, whereas younger adults tend to typically be hit harder by influenza B strains. Symptoms can be hard to differentiate from other respiratory illnesses and include sudden onset of fever, about 103 to 104 degrees Fahrenheit, cough, muscle aches and pains, and fatigue. Influenza can also be associated with secondary bacterial infection. If someone were to get influenza this flu season, it'd be hard for them to know if they're experiencing influenza or COVID-19 and potentially where and when to seek medical attention. Similar to COVID-19, older adults are disproportionately represented in those who experience severe outcomes, and this is more often due to the influenza A strain. This risk is increased for those over 65, with comorbidities like heart and lung diseases. The last of the respiratory conditions that we'll review today is pneumonia. In addition to being a potential complication of influenza, it can be acquired on its own. It's commonly caused by different serotypes of the bacteria Streptococcal pneumoniae. When contained within the lungs, it's classified within the non-invasive category. But once the organism invades normally sterile sites, such as the bloodstream, it's classified as invasive pneumococcal disease. Similar to influenza and COVID-19, we see that older adults represent high-risk populations for pneumococcal community-acquired pneumonia as well. This study aimed to describe the burden of vaccine-preventable community-acquired pneumonia in hospitalized adults by age. The study found that those adults 50 plus represented the biggest proportion of community-acquired pneumonia cases identified by all diagnostic tests for streptococcal pneumonia. Also similar to influenza and COVID-19, we see that risks of complications are higher for those with one or more comorbidity. This highlights the importance of screening patients not only for age, but also comorbidities when ensuring they're up to date on adult immunizations. So that was the bad news in terms of infectious diseases that are putting Canadians at risk. But the good news is that COVID-19 seems to have acted as a bit of a catalyst to promote interest in adults in getting immunized in Canada. The Canadian Pharmacists Association has released survey findings that show that more Canadians plan on being immunized against influenza this year than last year, and they're more likely to do so at their pharmacy. The survey also found that Canadians are putting a great emphasis on protective measures being in place when they make the decision to be immunized. Importance is placed on things like physical distancing, PPE, and limits on in-pharmacy patrons. And we'll talk about ways to put these in place to keep patients safe and comfortable getting their immunizations from your pharmacy. It's really encouraging to see this renewed interest in immunizations given that uptake in Canadian adults has traditionally been below targets that are set out by the National Advisory Committee on Immunizations, or NACI. For example, pneumococcal disease, the target is 80% of Canadian adults 65 plus receiving at least one pneumococcal vaccine. We can see from results of the Adult National Immunization Coverage Survey that only 58% of seniors reported receiving a pneumococcal vaccine in adulthood. We can see that pneumonia vaccine uptake is even lower at only 25% for Canadians below 65, but with medical conditions that put them at risk for pneumonia. Now, in the same survey that looked at immunization rates in Canadian adults, there were questions about reasons for not being vaccinated. And the most common ones were that young adults with underlying medical conditions had never heard of the pneumonia vaccine, and that seniors had the perception that vaccines were not necessary. An additional common reason for not being vaccinated is fears or misconceptions about side effects, potential harms from vaccination versus the benefit. There's a great public health role for pharmacists in making strong recommendations and increasing awareness of the need and benefit of vaccines. Now, we know that there's a role and pharmacists can have an impact, as published literature from Canada has found that pharmacists were considered a trusted source of vaccination information by 75% of the public, exceeding public health officials at 68.3%. And a systematic review and meta-analyses found that regardless of role, educator, facilitator, administrator, or vaccine administered, influenza, pneumococcal, compared to vaccine provision by traditional providers without pharmacist involvement. Now that we've refreshed our understanding of why protection is important and why it's crucial for us to do so more than ever and step up as public health promoters, we'll review current recommendations for how to conduct immunization services amid COVID-19 and which immunizations are recommended by guidelines, so you can provide not just the flu shot, but other adult immunizations as well. So NACI has put out interim guidance on continuity of immunization programs during the COVID-19 pandemic. And it explains that it's important for immunizers to continue to provide immunization services as disruptions can lead to accumulation of susceptible individuals, which could lead to outbreaks and associated increased burden on the healthcare system. This is already at capacity in the peak of COVID-19, as well as capacity issues post-COVID-19 if there's an accumulation of individuals whose vaccine statuses need to be updated. Furthermore, there's some evidence that those who miss vaccines at the regular scheduled time might be lost to follow-up. The guidance document highlights that older adults are particularly susceptible, as we reviewed, and thus should be the primary targets and prioritized for immunization services, along with immunocompromised individuals and pregnant women. For anyone whose immunizations are deferred, pharmacy teams should proactively add reminders to follow up for a later date to ensure that these patients don't remain unprotected in the long run. This can include adding pop-ups on pharmacy management systems to be flagged for future repeats, adding names to a calendar to follow up via phone call, or even running reports post-pandemic to identify high-risk or at-risk patients, for example, those 65 years and above. There are new challenges that COVID-19 presents for those continuing to offer immunization services, given COVID-19's transmission through respiratory droplet contact. But these challenges can be addressed, and we'll talk about it. To address the challenge of potential transmission of COVID-19, it's recommended that pharmacies systematically incorporate measures outlined by NACI in their guidance for influenza vaccine delivery in the presence of COVID-19 recommendations. Note that the recommendations were released about influenza vaccines but apply to immunization services in general. They include screening, physical distancing, infection prevention and control measures, or IPC, environmental cleaning, increased hours in staffing, appointment-based model, and technology to reduce contact. Screening questions can include, have you tested positive for COVID-19 and not yet been cleared? Have you demonstrated any COVID-19 symptoms on the day of your flu immunization? Have you experienced any COVID-19 symptoms within 2 weeks of getting a flu immunization? Have you traveled outside the country within the past 2 weeks? Are you living with an individual who currently has COVID-19 or has been out of the country in the last 2 weeks? And are you under self-isolation? The appointment-based model can help pharmacies plan staffing and cleaning appropriately and ensure that patient visits occur during off-peak hours or seniors' hours to reduce their potential risk of exposure to COVID-19 through other pharmacy patrons. It also helps to ensure that the number of people inside the pharmacy does not exceed regional limits. Technology includes the use of apps and software platforms that allow patients to book appointments, perform COVID-19 screening, complete influenza consent forms electronically to reduce time spent in the pharmacy, and passing papers. Now, we've talked about these points on the last slide, but with regards to spacing chairs in the waiting room, we want them to be 2 meters apart and consider wider spacing for those who may use mobility aids such as wheelchairs and walkers. On the signage, we discussed that should be up at the point of entry. Content to include is listed on this slide. It's helpful to have text as well as images for those who have different literacy rates and or those who don't have English as their first language. If possible, changes to practice due to COVID-19 should also be incorporated in audio formats. For example, sound systems in the pharmacy and on answering machines, and in writing, so in signs, social media, and on your pharmacy website. Signage should include points about not entering if they're ill or having had recent travel, asking patrons to wear non-medical masks or face coverings, using hand sanitizer upon entry and in the immunization room, maintaining respiratory etiquette, which includes covering the nose and mouth with a tissue if coughing or sneezing, using disposable tissues and discarding after use, and to use hand hygiene after having contact with respiratory secretions. Ensuring physical distancing includes being 6 feet apart. If any persons are identified with symptoms on arrival at the pharmacy, they should be instructed to perform hand hygiene, put on a medical mask, and be redirected for assessment. For example, to a healthcare provider or COVID-19 assessment site, depending on their symptoms. In terms of what PPE is currently recommended, immunizers and staff who are in close contact and unable to maintain a distance of 2 meters apart, so for example, those behind the dispensary, should wear a mask, a medical mask, and eye protection. For example, a face shield or goggles. Gloves are not needed unless administering an intranasal or oral vaccine, where there is contact with mucous membranes. This is because immunizers with gloves are less likely to sanitize hands and can spread the virus with their gloves. Patients should have non-medical masks on, and it's encouraged to have some available for patients if they forgot them at home. Medical masks can be used if needed, but non-medical masks for patrons allows us to conserve Canada's supply of PPE for healthcare workers. The exception to masks are those who are less than 2 years old, those with trouble breathing, and individuals who would be unable to remove their mask without assistance. Now, full PPE does not need to be worn as of this time, although practices could change depending on how COVID-19 evolves and based on community transmission rates, unless performing first aid or CPR. Because of the potential need to do this following an adverse event following immunizations, I recommend having a few sets of full PPE. This includes gown, gloves, medical mask, and face shield. We want these to be available at each shift the same way you'd have things like an EpiPen available for injection service purposes. The next two slides contain resources on donning and doffing PPE to help with ensuring that all staff is trained and comfortable in doing so. What can be helpful is to post these resources and have a buddy system where one person watches the other donning and doffing PPE in order to catch any potential missteps that may occur. Now, this is a resource from the New Zealand government for donning and doffing without an anteroom, as most community pharmacies don't have an anteroom like a hospital would. These are links to videos from the National Health Service, or NHS in England, so that you and your staff can watch. They're about 7 minutes long and provide good visuals to donning and doffing PPE. In addition to NACI's recommendations, CPHA has developed best practices for community pharmacy for the 2020-2021 influenza season. Components that stood out to me were the need to potentially adapt influenza immunization services to be by appointment, with certain hours for patients at high risk of COVID-19, and to be offered off-site, which can be at a patient's home or school, or even the pharmacy's parking lot. Before doing this, do ensure that your liability insurance extends to these models. Another helpful recommendation from CPHA is for pharmacies to make documentation like COVID-19, influenza, and adult immunization screening and consent forms available online so that patients can access them. While submitting them online would require a secure platform that may not be possible for all pharmacies to obtain, having the patient print and complete and bring in hard copies of forms to the pharmacy can help minimize patient time in the pharmacy, although do note that it would involve the transfer of objects between individuals. Now, I've put together an overview of a potential immunization workflow that incorporates the recommendations we touched on in the past couple of slides. The first step is setting up the immunization clinic. This is an excellent role for pharmacy team members. Identify patients who would benefit from immunization services. For example, run dispensing software queries for things like age or medication on the patient's profile that would indicate a risk factor, like insulin for diabetes. Call these patients to proactively book them for appointment-based immunization services off-peak hours to reduce their exposure risk. You may want to extend operating hours to accommodate this or even offer seniors hours. When calling to book patients, screen them for illnesses, travel, and close contacts. If they screen positive, do not proceed with booking them until 14 days after their exposure has resolved. Some pharmacies may elect to use technology, for example, online bookings, screening, and consent form, and this would reduce workload and contact time in the pharmacy. We'll talk about maximizing the encounter later in the presentation, but this is an ideal time to screen for other adult immunizations that the patient may be due for, as it then allows time to contact the prescriber if a prescription is needed. The next step is the appointment. The appointment-based model can help control the number of patients in the pharmacy to encourage social distancing, and it allows staffing to be updated to accommodate additional workload, for example, cleaning. Encourage patients to wait outside prior to their appointment and to come inside only and alone at the time of their immunization appointment. This would be accepted if they have a child or are a child or require a support person. This can be a bit of a culture change for those who are used to coming early to appointments. So patients can call or text when they arrive but note that some individuals may not have cell phones, and thus a workaround should be communicated if this is your system. Encourage patients to wear accessible clothing, like short sleeves, so that they don't have to roll up their sleeves, which would involve touching, or they don't have to take off their clothing over their head, which potentially could displace their mask. Patients should be screened again through passive measures like signage and active measures like asking questions or taking a temperature and consent obtained. To reduce transmission, you can ask patients to bring their own pen or have bins for clean and dirty pens. Note that all staff members should also be screened at the beginning of each shift. The third step is the entry. At the entry to the pharmacy, additional signage should encourage wearing a mask and sanitizing one's hands, both at entry of the pharmacy and in the injection room, and explaining COVID-19 measures that are in place. Step 4 takes place during the interaction. Medical mask and face shields should be worn by the immunizer. All communication with the patient should occur as the immunizer stands 6 feet away. Once the procedure has begun, talking by the patient or the pharmacist should be avoided whenever possible. Pharmacists can mark the 6 feet mark with tape on the floor and say something like, "Once I cross this line, there is no talking unless you're feeling unwell. So please let me know if you have any other questions before we begin." The encounter should be maximized. Take the opportunity to provide multiple services to prevent the need for repeat trips, which increase the risk of potential exposure, and promote protection. Also, maximize the time spent in the immunization room by prepping in advance and coming in strictly for immunizations, with the patient already ready and waiting in the room in advance with their sleeve rolled up. Ask the patient to look away from you to prevent them from coughing or sneezing or breathing on you during the interaction. Surfaces should be clean of clutter, patient pamphlets, and anything a patient may touch that can't be wiped down with disinfectant after each interaction. The immunization room should be cleaned after each patient or family of a patient has their encounter. This would include disinfecting wipes used to wipe surfaces such as door handles, chairs, countertops, and anything that the patient could have touched, including pens. The fourth step is monitoring. Set up the waiting room to encourage patients to stay seated to prevent roaming around the pharmacy and to encourage physical distancing. Taping distance squares to the ground and placing chairs within them can help. Do ensure that accessible options are available for mobility aids and support people. Ensure that all staff is trained on wearing full PPE in the event that it is needed during first aid following an adverse event from an immunization. The last step is the follow-up. So best practice is to inform the primary care provider that the patient has been immunized, as it promotes collaboration and shows that pharmacists have a public health role. We want to maintain a list or ability to identify, for example, dispensing software query, everyone who is immunized and worked a certain day in the event of a COVID-19 exposure and the need for contact tracing. Book follow-up appointments with patients for additional doses if any vaccine series is started on top of influenza, for example, meningitis or herpes zoster. So on the last slide, we discussed proactively reaching out to high-risk patients to schedule their immunizations. This and the next slide provide guidance on who NACI considers to be high-risk priority groups. Note that NACI states that healthcare workers should consider annual influenza vaccination as part of their responsibility to ensure the highest standard of care. And I'll give you some time to read these slides. Now I want to draw your attention to high-risk populations that are often surrounded by misconceptions. The first one is pregnant women. Pharmacists can and should immunize pregnant women who are at any point in their pregnancy. This is within our scope of practice, and the standard dose quadrivalent vaccine is safe and effective for them. We need to immunize pregnant women in spite of this common misconception. So now that we've talked about how to operationalize immunization clinics, we want to talk about how we can make the most of these interactions and our interactions with patients to help alleviate pharmacy workload and healthcare system capacity issues while we maximize protection for our patients. This can be done by maximizing the encounter. I define this as providing multiple adult immunizations that the patient would benefit from at the same visit in order to optimize the encounter and improve the patient's protection. You can see that these 3 patients on the slide have Band-Aids on each arm. And that's to illustrate that we want to provide not just protection against influenza, but we want to leverage the interaction to provide additional protection against vaccine-preventable diseases. This can apply to many different patient populations of varying ages. Instead of thinking, get your flu shot, we want to shift our mindset and actions to get your flu shot and more today. Now, the benefits of maximizing the immunization encounter are multiple. They include reducing potential for exposure, as the patient can be provided with many services in one appointment. This allows us to conserve infection prevention and control supplies, such as cleaning tools, and reduce workload because we screen and obtain consent once, and we fax the prescriber to notify once, and we clean the monitoring area once as well. It also enables the pharmacy team to build on the patient's openness to receiving a flu shot to discuss additional coverage, and ultimately provides protection for patients. If you are providing multiple injections on the same day, it's preferable to administer in different limbs if possible, or at least 2.5 centimeters apart if on the same limb. Live vaccines can be given on the same day, or if not, need to be spaced by at least 4 weeks. Inactivated vaccines can be given on the same day or in any relation to each other, with the exception of pneumococcal vaccines, which should be separated by at least 8 weeks if the conjugate vaccine is given first, or at least 1 year if the polysaccharide vaccine is administered first from each other. Here's a helpful resource to remember the spacing between the pneumococcal vaccines. If the conjugate vaccine is given first, we wait 8 weeks before the polysaccharide vaccine is given. I like to remember that we want the smaller number, so pneumo C13, to go first, and then we wait a smaller amount of time, only 8 weeks, compared to if the larger number goes first, the new P23, then we have to wait a larger amount of time, 1 year. We'll now go step by step to review how to practically incorporate maximizing the encounter into your practice. The first step is to be comfortable with immunization recommendations for adults. On this slide, we see that NACI makes the following recommendation for older adults. For diphtheria and tetanus, a booster dose should be given every 10 years. For pertussis, which is included with diphtheria and tetanus in the Tdap vaccine, we want to administer 1 in adulthood. For herpes zoster, it's recommended for all adults 50 years and above. For pneumococcal, the vaccines are recommended for all adults 65 years and above. And that's for both the polysaccharide and conjugate vaccine. And lastly, for influenza, it's recommended annually for all adults. Now, it's okay to slowly incorporate this into your practice. A good way to start is to pick influenza and 1 other vaccine preventable disease and screen everyone who comes into the pharmacy for a flu shot for that specific vaccine preventable disease. Once you become more comfortable with that, you can expand. So I would suggest starting with pneumonia because as we saw earlier in this presentation, there's a lot of overlap in those at risk and high risk for influenza and pneumonia. Similar to the last slide, these are recommendations for younger adults and those who are eligible for immunizations. We want to make sure we're comfortable with making recommendations to them. Again, we see that diphtheria, tetanus, and pertussis are recommended. The last childhood Tdap dose is generally received between the ages of 14 and 16, so adults tend to be due again between the age of 24 and 26 years, and then at 34 to 36 years for their diphtheria and tetanus booster without pertussis. Pertussis is also recommended during each pregnancy between 27 and 32 weeks gestation. Immunizing at this point in the pregnancy provides high levels of pertussis antibody to be transferred to the fetus and protects them for the first 2 months of life when morbidity and mortality from pertussis is highest. Younger adults should also be screened for meningitis B, as immunization is not covered in the public school-based program in Ontario, as only meningitis ACWY is, but can be deadly within 24 hours of symptom onset. Adults at highest risk include young adults 16 or 15 to 25 years old living in crowded areas like university and college dorms or military barracks. We also want to screen for the HPV vaccine, as women and men 9 to 26 plus years can benefit to prevent cancers associated with HPV, like cervical, oral, and anal cancers. Ideally, they should be immunized before being sexually active, but they can still receive protection from other strains that they haven't been exposed to, even after they've become sexually active for many years. HPV vaccines were introduced into the school-based program in Ontario for females in 2007, but only introduced in 2016 for males in grade 7. Therefore, many males who are eligible have not received the vaccine. Now, once you've screened and identified a patient who would benefit from an immunization, we want to check the publicly funded immunization schedule for Ontario. Publicly funded immunizations are those that are provided free of charge to patients through their local public health unit, their physician, or their nurse practitioner, or through school-based programs. Patients who are eligible for publicly funded vaccines should be referred to public health or their primary care provider. Now, in this resource, I find that Table 3 is also really helpful. It includes the high-risk criteria table, which shows which patient populations may be eligible for publicly funded vaccines, on top of those who are routinely covered as part of the routine program in Ontario. This often includes risk factors due to medical or lifestyle risks. The next step is to systematically and actively incorporate routine screening and recommendations for adult immunizations beyond influenza into your practice. This can include doing things like in-pharmacy posters, as we see an example here, and updated influenza screening forms that also ask questions about other adult immunizations. This allows the patient to be an advocate and start a conversation, as well as having the pharmacy team proactively engage with them. Here we see an example of a 18 by 24 poster, which I developed for whole health pharmacy locations that can act as a conversation starter for both patients and pharmacists, and that was on the prior slide. On this slide, we can see another example, which was again developed for whole health pharmacy locations, and it's an enhanced influenza consent form that allows patients to self-screen for eligibility for additional adult immunizations. For example, pneumococcal, shingles, and meningitis. And this is done based on their age. Now, we saw a significant increase in vaccine uptake the year that we made these updates to our influenza consent form. The next step is to ask yourself, what's within my scope of practice and do I need a prescription? Pharmacists in Ontario can currently administer vaccines for 13 vaccine-preventable diseases, in addition to the influenza vaccine. As you can see on this slide, they can be administered to individuals 5 years old and above. Remember that if public funding is available for the patient, according to the publicly funded immunization schedule that we reviewed in the last few slides, they should then be referred to their primary care provider or public health unit. Pharmacists in Ontario cannot prescribe vaccines and thus would need to contact a prescriber for a Schedule I vaccine, or if a patient requires a vaccine prescription in order to be eligible for private insurance coverage. Being aware of this can allow you to proactively fax prescribers for prescriptions and have them ready for the patient when they come in for their flu shot appointment. Now, many pharmacists ask about how one determines a vaccine schedule and how the decision is made regarding schedules. Well, the National Association of Pharmacy Regulatory Authorities, or NAPRA, determines schedule according to if the vaccine is recommended as part of a routine immunization program in most/all provinces and territories. If so, it's Schedule II, like pneumonia and meningitis vaccines. But if not, it's Schedule I, like herpes zoster vaccines and many travel vaccines. Note that provinces and territories can add additional conditions of sale, making them more restrictive than federal legislation at times. I've included a summary slide here of key information as it pertains to maximizing the encounter for immunization recommendations for various adult populations, and have included the schedule, the routine recommendation, whether routine public coverage is available, and the pharmacist's scope of practice in Ontario to inject. We'll use this knowledge as we review 3 case presentations, so we'll give you a moment to review yourself. Okay, so our first case. Our first case is Mateo, who's an 18-year-old male born in 2002. He comes into the pharmacy to pick up OTC items as he's moving back into his university residence. You're on duty and decide it's an opportunity to ensure that Mateo is protected this school year. Mateo has his childhood immunization records as he recently requested them from his local public health unit as a requirement for living in his residence dorm. This can be done online or in person, depending on the specific public health unit. You ask Mateo about his immunization status, and he said that his dad made sure he was up to date on all childhood and school-based immunizations. You decide to specifically review ones with him that are typically recommended for young adults. For diphtheria and tetanus and pertussis, he's received his last dose through the public childhood immunization series at 14 years, and therefore he isn't due for it until he's 24 years old, as it's once in adulthood for pertussis and a booster every 10 years for diphtheria and tetanus. For meningitis, he's only been immunized against meningitis ACWY in the school-based program, and therefore you recommend it today as he'll be living in residence. For influenza, he hasn't received a dose yet this season, so you recommend it as well. For HPV, it turns out that Mateo actually hasn't received this as part of the school-based program, as it was only introduced in the 2016 year for grade 7 males. This is those born on or after January 1st, 2004, and thus he missed it as he's born in 2002. You recommend it to him. Mateo appreciates that you reviewed his immunization status with him, as he didn't realize he was due for vaccines beyond the flu shot, and his dad will be reassured that he's once again protected. He's already worried about him going away to university, so this is one less thing that his dad has to worry about. Matteo doesn't qualify for public funding for either the meningitis B or HPV vaccine, as he doesn't meet the high-risk vaccine program criteria outlined in Table 3 of the publicly funded immunization schedule. But he does have a university plan that covers 70% of vaccines with a prescription. You immunize Matteo against influenza today, and you fax his nurse practitioner for a prescription for the meningitis B vaccine and HPV vaccine. And you schedule an appointment with Matteo for next week to administer both of them to him on the same day. Case number 2 is Chantal. Chantal is a 66-year-old female with diabetes and hypertension. She calls to request a medication refill, and you decide it's an opportunity to discuss adult immunizations with her as well. Chantal expresses that she was fairly up to date on recommended immunizations until COVID-19, and then she experienced interruptions as she was trying to stay home to physically distance, and her doctor's office stopped most in-person visits. You review her past immunization status with her, and you see the following. She's received a Tdap vaccine at 58, and thus has received an adult dose of pertussis, and isn't due for a 10-year booster of diphtheria and tetanus until she turns 68. She has started her herpes zoster RZV series in March 2019, about 19 months ago, but she didn't get the second dose yet. She's therefore due, and you recommend that she complete the series to ensure maximal protection. She gets the flu shot every year from the pharmacy, but hasn't received hers yet this year, and so you recommend that today as well. Lastly, she did receive polysaccharide pneumococcal vaccine at 52 when she was first diagnosed with diabetes, but she didn't receive the conjugate vaccine at that time, despite her comorbidity putting her at risk. And she's now older than 65 and is therefore eligible for her age dose of the polysaccharide vaccine, which is given to adults once they turn 65, as long as it's been 5+ years since their last polysaccharide dose. You recommend both pneumococcal vaccines, the conjugate vaccine from you now, and then the polysaccharide vaccine from her doctor, as it's publicly covered for those 65+ in 8 weeks. Now, many patients and providers wonder if interrupting a dose series means it needs to be restarted. And according to the Canadian Immunization Guide, it does not, with very few exceptions. The series should be resumed as soon as possible in order for the patient to receive maximal protection once full antibody concentration is achieved once the series is completed. For Chantal, this means we could complete her herpes zoster series with the second dose without having to restart the entire series, even though it's been 19 months since her first dose, whereas the recommended dosing schedule is 0 and then 6 to 12 months later. Another question that will likely come up this season is what's the difference between the standard dose quadrivalent vaccine and the high dose trivalent influenza vaccine? Now, the trivalent vaccine has 2 influenza A strains and 1 influenza B strains included, whereas the quadrivalent vaccine has 2 influenza A strains and 2 influenza B strains. While the trivalent vaccine has coverage for 1 less influenza B strain, it has 4 times the antigen content for the 2 influenza strains and 1 influenza B strain, which it provides protection against. This can be helpful in adults 65+, as it allows them to mount a greater immune response to the influenza A strains that tend to cause more severe outcomes in older adults. This can be especially important as our immune systems wane as we age, which makes it more difficult to mount an immune response. The last common question I see from older adults is, do I really need both pneumonia vaccines? And the short answer is yes. The 2 vaccines provide coverage against some different serotypes and are different with regard to their makeup. The conjugate vaccine has a bacterial polysaccharide that's covalently conjugated to an immunogenic carrier protein. This means that the conjugate vaccine mounts a T cell response, which in turn induces immune memory via the development of memory B cells. B cells then produce immunoglobulin G, or IgG, which is responsible for sustained immune response, versus IgM, which is a marker for early infection but doesn't indicate sustained immune response. In addition to providing a longer duration of protection, the conjugate vaccine also provides herd immunity. With herd immunity, even if an individual is not immunized, if enough people in the community are vaccinated, then the individual is protected. In contrast, the polysaccharide vaccine induces hyporesponsive effects, meaning that there's less of an immune response each time a subsequent dose is given. In terms of booster doses required with the polysaccharide vaccine, this slide lays out NACI recommendations. In essence, there's what I like to call that age dose, where all adults should be immunized with the polysaccharide vaccine when they turn 65. This dose is publicly covered in Ontario. People younger than 65 may also benefit from the polysaccharide vaccine if they have comorbidities that put them at risk for pneumonia at a younger age. Things like diabetes, lung disease, heart disease, renal or liver disease. This dose is also publicly funded in Ontario if high-risk criteria is met, which it is for the examples I just mentioned. These patients should then wait 5 years or more between their first dose and their age dose. So if the patient was immunized at 62, they wouldn't receive their age dose at 65, but rather at 67. Lastly, for patients with certain high-risk criteria, example, immunocompromising conditions related to disease or therapy, a lifetime booster is recommended to protect against invasive pneumococcal disease, or IPD. IPD occurs when the bacteria causing pneumonia moves into a previously sterile site. So for example, from the lungs into the bloodstream. So as an example, for a patient who is 35 and is HIV positive, they would receive their first dose now. They would receive one lifetime booster dose 5 years later at 40 years old. And then they would receive that age dose once they reach 65. Getting back to Chantal, who's calling to request her medication refills, and you took the time to get her back on track regarding adult immunizations going into flu season. You schedule an appointment with her later so that she can receive a high-dose flu shot, the conjugate pneumococcal vaccine, and complete her herpes zoster vaccine series on the same day as her medication refill pickup. At that time, you also fax your primary care provider to let them know that she's now up to date, but that you recommend they follow up to book the publicly funded polysaccharide pneumococcal vaccine in 8 weeks from now. Our last case involves Lily. Lily is a 36-year-old pregnant patient who comes in to purchase diapers. You get to talking and you take the time to review her immunizations, which are recommended during pregnancy. Lily made sure that she was up to date on immunizations before conceiving, but she's interested in doing everything she can to protect herself and her soon-to-be-born baby. You review that she received her adult Tdap vaccine with pertussis protection at 24 years old, and so the diphtheria and tetanus 10-year booster is only due at 34 years. She therefore isn't due for another diphtheria and tetanus booster until 44, but she will be due for a pertussis vaccine at 27 weeks gestation. You discuss with her that this dose, unlike the others, isn't publicly covered, but does provide protection for the first 2 months of her child's life. Lily hasn't received her influenza dose yet, as she heard from a friend that pharmacists couldn't immunize pregnant women. You explained to Lily that pharmacists can and should provide influenza vaccines to pregnant people as it's safe and effective. Lastly, you review Lily's HPV immunization status, and she confirms that she was immunized at 24 years old, along with her last Tdap vaccine. You provide Lily with her influenza vaccine today, and you fax her physician to recommend a Tdap vaccine. The physician is open to issuing a direct order, as the pharmacy is more convenient for Lily. A direct order is an order to perform a controlled act for only one patient for a specific intervention, in this case, administering a Tdap vaccine. This is different than a medical directive, which is an order authorizing those identified in the directive to perform a controlled act or a series of controlled acts under specific conditions for any patients who meets the criteria set out in the directive. In Lily's case, the physician writes pharmacist to inject on the prescription to issue a direct order at 27 weeks gestation. And at that time, you provide Lily with her Tdap vaccine. So now that we've reviewed adult immunization recommendations for vaccines in the COVID-19 era and how to incorporate screening for and administering multiple vaccines on the same day to maximize the encounter, we'll review some operational tips and tricks. So changes to the pharmacy influenza program. The first thing to be aware of is changes to the UIP program in recent years. Last year, it was expanded to enable pharmacists to provide flu shots to retirement home residents in their retirement home, as long as it truly was a retirement home, not a co-op or seniors apartment, and was located within the boundaries of the same public health unit as the pharmacy. This year, we've already seen the program expand to enable pharmacists to provide the high-dose trivalent influenza vaccine to adults 65 years and above, and to enable influenza vaccines outside of the physical boundaries of the pharmacy. Additional details continue to be rolled out, so look for communications from the OPA. Currently, scope expansion is being considered to enable pharmacists to immunize children as young as 2 years old against the flu. If this comes into effect, it may be prudent to take the OPA's Mastering Pediatric Injections course for any pharmacists who are hesitant to immunize little ones. A crucial, if not the most crucial thing to know about integrating immunizations into the pharmacy workload is that it's truly a team effort. You can see that there are too many steps for any one individual to take this on, but that they are possible if everyone from the front shop staff to the pharmacy students to the technicians, the owner, the manager, come in and play a part together. Having everyone on the same page and being aware of the program goals can also ensure that patients receive consistent and repeated messaging. Once you have the whole team on board, you can find ways to integrate immunization screening and administration into everyday practice. One way is to integrate screening for vaccine-preventable diseases and patient populations into seasonal campaigns. For example, proactively engaging with patients about if they have upcoming travel plans in the spring around March break or around May when university students graduate and go backpacking. You can incorporate screening into clinical services like meds check as you discuss comorbidities and could quickly identify a patient's risk factors like asthma and COPD for pneumonia, and smoking cessation, where you recommend a vaccine to all patients where smoking is a risk factor. Lastly, staff members should look out for triggers that vaccines may be in order. For example, when patients mention to the team that they're working to the team who's working the register that they're looking forward to retirement. This could be a trigger that the patient is likely in their 50s or 60s and that they may benefit from vaccines, especially while they might have their private vaccine coverage, which is about to expire. Another operational tool that can help with reducing workload associated with providing immunizations is having a pharmacy recommendation template. This way, the bulk of the work is done once, and then the templates can be leveraged time and time again. You can see here an example that I've developed for pneumococcal recommendations at Whole Health, and I find it helpful because I don't have to write out the recommendation every time, but instead, I can simply check boxes. It also has a rationale and references integrated so the prescriber can check if they'd like, and it also builds a respecting relationship where they can see that I'm making evidence-informed recommendations. It also acts as a mini prompt for myself anytime I see a patient who might fall within this criteria and would benefit. I suggest having one recommendation template per vaccine preventable disease. Now, this year has had many changes, and many of these come with associated costs. Speaking with colleagues, we've come to the conclusion that this is absolutely the time, if you aren't already, to start charging for injection services. Patients have started becoming aware of fees due to COVID-19, and they are willing to pay for the convenience of visiting a pharmacy versus a busy family health team and sitting in the wait room. It can help to put up signage that this is the practice for all patients moving forward, and that it helps to cover the assessment as well as PPE and infection prevention and control measures that are in place. Don't sell yourself short in that it's not only PPE and IPC costs, but it also covers the time and expertise required by the pharmacy team to ensure that patients are screened and vaccinated. In the last few slides, I've incorporated some additional helpful resources, including how to set up vaccine injection clinics and empower patients to track their own immunizations. COVID Alert is an app developed by the Government of Canada to help limit the spread of COVID-19 and prevent future outbreaks. It uses Bluetooth and the exchange of random codes to see if you've been in contact with anyone who has tested positive for COVID-19. The app can let people know of possible exposure before symptoms appear so that they can self-isolate and protect their communities. As you'll be coming in contact with patients, I highly recommend downloading the app and recommending all patients who come in to be immunized to also download the app so that any exposures can be identified this way as well. The Can Immunize app is also a good tool for patients to keep track of their immunization status. For those who prefer hard copy options, Immunize Canada also has the yellow cards that can be ordered or printed online. Lastly, 411 Vaccines is a site where patients can look up vaccination clinics near them. Pharmacies can and should register so that patients can find a pharmacy offering adult immunizations near them to help reduce barriers to access. It's also free advertising for your vaccine services, and you can specify specifically which vaccine preventable diseases you immunize against. So thank you for joining us today to review operationalizing adult immunizations, flu and beyond. In summary, our key learning points are here. Older patients are disproportionately at risk for COVID-19, influenza, and pneumonia, and associated complications. Pharmacists have an important public health role as immunizers for adult vaccine-preventable diseases. Infection prevention and control measures should be in place to protect patients and staff from COVID-19. Screening for and confidently recommending adult immunizations is crucial to provide patients with protection. And maximizing the encounter by providing multiple vaccines at the same visit, for example, flu and more, can help ensure patients are protected and promote workflow efficiencies. I've included links to some additional resources that you might want to read or access if time permits. I've also included references used for the entire presentation here, and on the next slide. Before opening up the floor to take questions, I'd like to remind learners to complete the program's evaluation form. Thank you very much for joining me this evening, and all the best as you incorporate immunizations into your practice this season and beyond.
Thank you. That was very comprehensive, very much appreciated. We did get some questions, so let's just see what's up. You might have answered this. Are the vaccines you mentioned okay to administer to patients on the same day as the influenza injection? For example, a shingles or pneumococcal vaccine.
Yes, so one of the great things and one of the reasons why maximizing the encounter is even possible with the flu shot is that these vaccines can be given on the same day as the flu vaccine. And that's true for herpes zoster, for HPV, for pneumococcal vaccines. Those are all included. If you are giving a live vaccine and it's not given on the same day as another live vaccine, then you do need to wait 4 weeks. If you're giving an inactivated vaccine, it can be given in any relation to another vaccine, whether it's on that same day or any time thereafter. The exception that I had mentioned was specific to vaccines that protect against the same vaccine preventable disease. So for example, with pneumococcal vaccines, there is a time frame to wait between the two of them. Similar to herpes zoster vaccines, there would be a time frame to wait between the two of them if a patient did receive both.
Okay, thank you. Also, a question about requirement to need more than one pneumococcal 23 vaccine.
Oh, is that?
That's for you.
That's a question. Okay, so
Is there a
let me know
requirement?
if there's a specific component to that question, but for patients who are getting that kind of age-based dose, so they don't have chronic comorbidities that put them at risk for pneumonia or lifestyle risk factors that put them at risk, it's really just the age. Then at 65, that's when they'd be eligible to receive the Pneumovax dose. If they are a patient who has other comorbidities that put them at risk, so they're over 50 and they smoke, or they have diabetes or COPD or liver or kidney disease, then they would want a dose when they're 50 and older, or when they have that condition that puts them at risk. And then they would want another dose when they do turn 65, as long as it's been more than 5 years since that original dose. And then there's one patient population that are kind of like the highest risk patients. So those are the ones that are immunocompromised, either due to a medical condition, such as HIV, or a medical therapy. So for example, a biologic. And for those patients, they would receive that first dose. They would then receive a booster 5 years later. And then once they hit 65, they would get their final age dose. So in total, 3 doses for them.
Okay, now this one's a toughie.
Oh no.
It's a hard one to answer. So for patients over 65, is the high dose better than, is the high dose quadrivalent better than the high dose trivalent, which is covered by Ontario?
So in an ideal world, and I feel you on this one, we would have on the Canadian market the high dose quadrivalent vaccine. That, in my opinion, would be ideal. Unfortunately, we don't on the Canadian market, and luckily in pharmacies this year, we have the high dose trivalent vaccine. So we have to weigh our options, and it is something you can have a conversation with the patient about, letting them know that there's 2 influenza A strains and 1 influenza B strain, whereas in the quadrivalent, there's the 2 influenza A strains and 2 influenza B strains. But we need to weigh what impacts those who are 65 and older more. So we know that influenza A tends to be responsible for more infections in older adults and more complications in older adults. So we really want to make sure they have that protection and as much protection as they can against influenza A. And in the case of older adults whose immune systems are waning and they can't mount as great of a response with the regular amount of antigen in vaccines, we want to have that higher concentration, which we find in the high dose vaccine, so that they can mount a greater response to those 2 influenza A strains and the 1 influenza B strain. I think one thing that actually might come up this year is that pharmacies may run out of the high dose trivalent vaccine. And so again, then that's a conversation with the patient in terms of, do they have access to the high dose somewhere else? If not, would waiting to get any vaccine put them at risk of influenza? And if that's the case, maybe they would even want the standard dose. So it is going to be a patient by patient conversation, but something that you can anticipate. I know physicians saw it last year when they ran out of high dose as well.
Yes, there was a question earlier on about the allocation of high dose versus regular dose, and reached out to Alan Malik about that one. We don't know how the Ministry of Health actually allocated the different vaccines to pharmacy. There's a lot of reasons behind it, what you did last year, et cetera, et cetera. And because we're first year in high dose, they don't have any history. And it may be that they're looking within the public health unit and how many high dose got sent out that last year. But it's going to be a really tough situation, I think. There's going to be a shortage no matter what. So it's important that your very high risk patients, I think, get the high dose as soon as possible. Someone asked about
getting, and I think pharmacies already are booking appointments.
Sorry, go ahead.
Oh, sorry. I was going to say already some pharmacies have already received their vaccines or are injecting right away. Some pharmacies who might not have them yet or might even have run out already, doing dispensing software queries to identify your highest risk patients and booking them in to make sure that they're protected and they get not only the flu at that time, but other vaccines. For some patients who might be at risk and you've run out of flu vaccines, a good as well would be to make sure they're up to date on their other vaccines and then scheduling them to come back for their flu shot when you do have flu shots. So at least you're giving them some protection, especially if it's for a respiratory condition, not delaying that, but then making sure we follow up to get their flu shots.
Here's another good question about how long does protection from the influenza last? So if we're giving flu shots now on the 6th of October, is the protection against the flu going to last for the entire time?
It should still last for the duration of the flu season in Canada. So really that fall to early winter. So there's no reason to delay in order to try to get more out of it kind of later. I would say what a great risk would be is delaying too much and them getting sick in the earlier portion, especially as we're now starting to see that second wave of COVID. So I wouldn't delay.
Okay, thank you. So ODB covers patients over 65 for the high dose flu shot. If I have a patient who is a cancer patient and I feel requires high dose, what do I recommend for that patient?
Yeah, so if that patient, and it could be your recommendation, it could be the patient, it might even be that their primary care provider has recommended it. You can purchase it separately through a private funding option, but it wouldn't be able to be covered through the publicly funded program, even though they are at risk and could benefit from it. So you could order that separately and they would have to pay out of pocket or maybe their insurance might cover it.
Okay, here's a real practical question. If you're giving 3 vaccines at the same time, you give 1 in each arm, and where do you put the 3rd one?
And then you move the 3rd one 2.5 centimeters down or to the side from one of them. I actually have seen this before. It seems to be especially common when you're doing travel. In that case, when I do travel, it's a good opportunity for me to make sure patients are caught up on their regular vaccines. So they often then need to do something like a Tdap vaccine and a shingles vaccine. But then they might also be traveling to somewhere where they need another vaccine, like a meningitis vaccine, for example. So it is common, it happens. It's up to you and up to them. I would maximize the encounter and do 3 or 4 if it's indicated. If it's too much for the patient, and you might even see after you do the first two, it could be okay to do another one at another date, especially because for inactivated vaccines, you don't have to wait any certain amount of time between them.
Okay. So the very high risk can have 2 doses younger than 65 for Pneumo 23. Then they wait until age 65. If the high risk person is quite young, 50 to 55 years of age, they would have still only 2 doses before they turn 65.
That's correct. Because we see that hyper-responsiveness with the polysaccharide vaccine, they get less of an immune response that occurs every time they get a booster dose. So we don't want to give them too many, or else they won't be seeing that benefit from those boosters anyways. What I would say to recommend you do to ensure that they're protected is that they're not just getting that polysaccharide vaccine, but make sure they're getting that conjugate vaccine as well. That conjugate vaccine is just a one-time dose. There's no boosters. And if they got the polysaccharide vaccine first, you would want to wait a year before the conjugate vaccine. If they got the conjugate vaccine first, you would wait 8 months before the polysaccharide vaccine. So let's say you did a polysaccharide vaccine at 50. You could do the conjugate vaccine at 51. You could then do the booster dose for the polysaccharide at 55, and then that age dose for the polysaccharide vaccine at 65. So in total, they might have actually gotten 4 doses of a pneumonia vaccine.
Wow. So if a patient gets a low dose or regular dose flu shot, can they get a high dose later? Say you don't have it in stock and they want to get the regular one.
Yeah, I think more from a health equity perspective right now, because we know there's so much demand for flu shots, I wouldn't recommend using 2 on 1 patient. I just don't think we're going to have the supply to be doing things like that. I know it can seem like, okay, let me just cover them with something and then cover them with something better when I get it, but I wouldn't really recommend that so that we can immunize as many Canadians against influenza this year. So that would be my recommendation.
Okay. Someone asked about high-dose quadrivalent flu vaccine available for a patient willing to pay for it. I think you know, well, I'll let you answer that.
High-dose Trivalent is available in Canada. If they're over 65, it's publicly covered. High-dose Quadrivalent vaccine isn't available in Canada, so they wouldn't have access to it this year, hopefully in future years. And then if they're not publicly covered, for the high-dose Trivalent, they may be able to purchase it privately. And this is the case for other provinces outside of Ontario, where the public coverage is really restricted to things like 65 plus and in a long-term care home, where then there might be private purchase as an option for other patients who don't meet this criteria.
Okay, and here's an interesting one. Do I need a booster dose for Hep B if I was given it more than 10 years ago?
If you're wondering, even as the pharmacist for Hep B, sometimes people don't mount the immune response, and so what's generally recommended is to go test the titers and see if you're at appropriate levels, and then that'll let you know if you need additional immunizations.
Oh, okay, good to know. So we've come to the end of the questions. We've had a few people asking about slides, and I'll mention that now. Thank you, Tiana. It was amazing. Thanks for answering the many questions. We've had some really good questions tonight. Didn't stump you, so that's good. Again, I want to thank Pfizer Canada for their support of the webinar today, and I want to thank all of you for coming. So when you leave this webinar, you will be getting a window that will pop up with an evaluation, and we would really appreciate it if you could fill out that evaluation. It's very important to us. Also, later this week in your inbox, you will get an email that contains a link to a continuing education program that will consist of this recording and all the slides for the recording, slides for the recording. In addition, if you would like to get continuing education units for this, what you will need to do is answer the questions based on the content and pass with a 70% mark within 2 tries, and then you'll get a letter of completion and your CEU credits. If you, at any time, if you have any questions, just email education@opatoday.com. Again, thank you, Tiana, thank you, Pfizer, and thank all of you for coming this evening, and have a great night, everybody. Take care.